decreased GFR. It's not very steep, very low, but he does have decreased GFR. It's on the lower, even for age normalized values. And so he's somewhere in this range, right? At this point, in terms of management, he doesn't have a lot of albuminuria. You don't need to worry about complications related to increased albuminuria. You do want to worry in this man about drug toxicity. You might have just a remote eye on whether he might have any acid-base abnormalities or any metabolic or hormonal complications, but his kidney dysfunction is not very severe. As you get more worsening kidney function, you start worrying about more significant complications, cardiovascular disease, fluid overload, anemia, malnutrition, and so on. This is the sort of consensus guidelines on how you divide up kidney disease into stages with its associated GFR, and you've seen this. Stage 3 kidney disease is divided into 3A and 3B to subdivide out those with kidney function between 45 to 59 on GFR and 30 to 44. And so he probably falls somewhere in this range of 3A. And then you look to see, does he have albuminuria? And we'll come to that in a minute. He did dip positive for albumin in the urine, which when you dip positive, you almost certainly have somewhere in the range of about 200 to 300 milligrams of albumin per gram of creatinine. And he does not have macroalbuminuria, so he's in this range here. When you think about how this translates into kidney progression, on the bottom hand figure, you see stage 1 through 5 of stages of kidney disease, and on this axis you have albuminuria at 30 to 300, etc. And he's probably in this range, so he does have some risk factors for progression. Now, the risk of kidney failure is not uniform, and you need to keep that in mind. Relative risk compared to white patients, African Americans have a 4.4-fold higher risk of progression, Native American 3.57, and Asians about 1.6-fold higher. So when you have a patient coming into your office where some risk factors, also look through the lens, through a racial lens. And the reason I think it's important to do it from a risk factor perspective is because whatever complex genetics individuals have, the risk of kidney disease progression seems to be higher in certain groups. And the reason that's important is because then you need to be more vigilant of managing them and of following them. And that's important. The second thing you should do is look at lab data. I know virtually no primary care practice now will have a patient with kidney disease and spin their urine and look at the urine. It becomes very challenging to do it with OSHA requirements, etc. But if you had the opportunity to look at the urine, you'll often see, on high power under the microscope, these broad casts. These are broad hyaline casts because their tubules are dilated. Sometimes these casts can look waxy in appearance with these cracks in them. These are waxy casts, and they're broad. And this is a very important telltale sign of chronic kidney disease. You can do a renal ultrasound. The thing you're looking at in the renal ultrasound in the report is the kidney size. Kidneys that are shrunken are compatible or aligned with having chronic kidney disease, and cortical thickness of the cortex. Remember, there's kidney parenchyma is divided into the medulla and the cortex. The cortex is the outer rim of kidney tissue, and as kidneys become diseased, the cortex shrinks, and so the radiologist may point out to you not only the kidneys are smaller in size than normal, but there's thinning of the cortex, the indication of chronic kidney disease. Now, in this complicated figure from this New England Journal paper published by Andy Levy recently, you can evaluate the risk of kidney failure. And I leave this just as a reference for you to look at that there are many different risk failure tools that predict progression, much in the same way as there are these heart failure risk predictors like the Reynolds equation or the Framingham equation. Well, we have a similar set of equations in patients with kidney disease. My favorite is the KFRE risk prediction equation. It was developed by Nav Tangri. It's a laboratory-based equation to predict kidney progression, and it accurately predicts CKD stage 3 to 5 progression over 5 years. And depending on which variable you use, I mean, I like to use just the age, GFR, and sex. You factor in this guy is 78. You factor in that he's male. You factor in that his estimated GFR is X, 59 or whatever, and you will come up with a prediction of what's the likelihood this person will progress in over a 5-year period. Now, it is important to remember then that this is what happens normally after, in a male up to the age of 45, you start getting this progression of 1 mil per minute per year on average. But people progress at different rates. And so with that risk fracture equation, you will get different sort of degree of progression over 5 years. They might say there's a significant progression, and different people progress. And the goal of your treatment, your management, and getting the nephrologist involved is really to take someone who's a fast progressor, progressing at 5 mils per minute per year, bring them up to the normal level of progression, which is 1 mil per minute per year. So I always tell my fellows that my role as a nephrologist is to sit down with a patient, plot out what their rate of progression is, and try to convert them from a fast progressor to a slow progressor. That is the goal. The metric, the most important metric to our patients for success is, can you prevent me from developing end-stage renal disease? And I do that from a tactics perspective by converting high progressors into slow progressors. Some patients progress linearly, other patients progress in a nonlinear fashion, and you need to bear that in mind. So you might have someone who's progressing linearly at around 2 mils per minute per year, and you're saying, that's not so bad, but then suddenly they have a steep decline, and they're now fast progressors. So keep an eye on these patients and be cognizant of the fact that progression rates aren't completely linear in everyone. Managing progression factors are shown here, the number of them, these, obviously high level of albuminuria, hypertension, poor glycemic control, smoking, hyperlipidemia, and drug use. Drug use can be not only illicit drugs, but even regular over-the-counter drugs like non-steroidals like ibuprofen and naproxen. You need to manage these progression factors, particularly blood pressure and glycemic control, very important. Get the patient to stop smoking, treat their hyperlipidemia with a statin, and tell these patients to knock